Good morning, everyone. My name is Dr. Nazanin Homafar. I'm one of the generalist OBGYNs at UCSF. We're going to let everyone log in right now, take a minute to do so before we get started. Welcome, everyone, to the fifth installment of the Women's Health webinar series. In the past few weeks, our focus was on prenatal care at UCSF during COVID-19, gynecologic care, and fertility care. And now we'd like to turn our attention to our gynecologic oncology department. Today, you'll hear our panelists discuss care for UCSF patients with cancers of the reproductive organs during this time, including expectations for surgery, plans for chemotherapy and radiation, what to expect if you're in survivorship, and the latest updates on our research studies. I'm very excited to have three wonderful panelists: Dr. Lee Mei Chen, Director of UCSF's Gynecologic Oncology Division; Dr. Megan Swanson, one of our gynecologic oncologists; and Rebecca Gaffar, who's one of our clinical research coordinators. We also have live interpreting Spanish that's happening right now. So our wonderful Spanish interpreters at UCSF are joining us and will be able to interpret for any of our Spanish speakers who might be listening. Before we get started, I'd love for you to fill out a poll so we can figure out how you heard about us and what topics are of interest to you. I'll give us a minute to have our attendees fill out the poll and then talk about some of the ground rules. I'll give you another 10 seconds. Okay, we'll close out the poll now. 56% of you heard about us from MyChart. 33% heard about us through the UCSF website, and some of you heard about us from a friend or word of mouth. We were a bit delayed this time in getting our MyChart message out, so we're so excited that some of you could join us through MyChart. And then in terms of where you are in your journey, 33% of you, or 3 of the 9 of you who responded, have recently had surgery. 22% are awaiting initiation of chemotherapy or radiation, and 67% of you, 6 out of the 9, are survivors, which is amazing, which is where we'd love to see you all, and I think should give us hope that we still continue to see our patients on the other side, and we're eager to provide care for all of you at this time. Today's format will include about 45 minutes discussing some topics on your care at UCSF, and we'll leave about 15 minutes for Q&A at the end. We'll aggregate the questions that you send to us. If they're not answered, please reach out to us and reach out to the Gynecologic Oncology department individually. We want to remind our participants today that today's information is meant to complement everything you've received. If you have any questions on specifics, we urge you to reach out to your healthcare provider and ask those questions, either through MyChart or through a telehealth visit. Obviously, when the city liberalizes shelter in place, our strategy to meet the needs of our patients will also be changing. Today's information is most relevant to your care in regards to COVID-19 and in the aftermath, as we also try to make up for the visits that were potentially deferred. So today, I'd like to start with Dr. Megan Swanson, who's one of our gynecologic oncologists, and ask a few questions about what patients can expect in the outpatient clinical setting. Dr. Lee Mei Chen will focus a little bit on chemotherapy and radiation for our patients, and also what they can expect from surgery. And Rebecca Gaffar will talk to us a little bit about, give us updates on the research studies that are going on. Dr. Swanson, for patients with a new diagnosis of cancer, what can they expect? And are you still seeing patients in clinic?
Thank you so much for hosting this panel, Dr. Humafar. Yes, we are definitely still seeing patients, and we are trying our very best to accommodate cancer care during this unprecedented time of this worldwide pandemic with COVID-19. I think most of the participants on the call, it seems, have established care, and it seems like most have had surgery or are in survivorship phase. So potentially not quite as relevant for them, but just to answer the question, we definitely are still seeing new patients as diagnoses are made and referrals are coming in. We're trying our best, and we're taking it on an individual case-by-case basis, whether it's possible to accommodate the new patient visit with Zoom or telehealth, or whether we really do need to see the patient. Most new patients we are seeing at some point in the clinic and making a plan for initiating therapy, be it surgery, be it chemotherapy, be it radiation, depending on the individual circumstances. We're trying our best. The medical center has a series of policies to screen patients, and many of you who have been in know that there's a citywide ordinance where we are not able to, unfortunately, accommodate visitors to optimize health and safety for all people coming in. So we're trying our best to balance safety, minimize risk, and also provide cancer care.
Thank you, Dr. Swanson. And so I know you mentioned this, but just to be clear about it, are you operating on patients right now?
We are. The medical center has prioritized, operating in a timely fashion on our patients with gynecologic malignancies and other cancer diagnoses. There's been a process to ensure that we are able to offer surgery in a timely way. So absolutely, we are still working on providing those services.
And how about blood work and imaging? Because I know for your line of work, that's often very important for the care of a patient. Are patients able to get that at UCSF or either locally if they're coming from afar?
That's a great question. Yes, we are still, as you mentioned, imaging is often timely and essential as part of one's care through the process. When imaging studies are necessary to make a treatment decision, it is for those people who we are still able to accommodate for different imaging studies. It's all just has been a balance of minimizing risk to people coming in and moving through the medical center, but also there's certain information we just absolutely need to have in order to move forward with the treatment. So it's all about minimizing risk, minimizing harm, but still proceeding with things like imaging studies when necessary and laboratory studies when necessary. If people live far away, we're used to that situation. We take care of a lot of people from all over the state. We have worked with our practice managers and nurses and the local treating oncologists to figure out where it's possible for people to get these studies safely. Different imaging centers have different regulations and restrictions at this time. So it's when people are having their studies outside of UCSF, it's a bit case by case, but we're working to help people get the imaging that they need to move forward with treatment.
And I'm assuming if your patients have any questions about where they might be able to go, then the triage nurses that work with you are able to provide that information for patients who call.
Yeah, I would encourage people to reach out in the same ways that they usually do, either by phone or by my chart is a great way to be in touch with us with questions regarding where they should be going for their imaging.
I know we've all experienced an increase in our use of telehealth in the past few months, and it's really challenged us to think about how we can deliver care via telehealth. Who is the Gynecologic Oncology department seeing for a telehealth visit?
That's a great question, and it's definitely changed our practice quite a bit. In some ways, I think it's expanded opportunities for people who live really far away. We have taken this on a case-by-case basis, but I'll provide some general guidelines. For our patients, especially our patients in survivorship who have completed their treatment and are in a surveillance phase, we have tried to accommodate the majority of those visits via telehealth. We screen the patients prior. If people do have concerns or if there's an issue that they feel may not be able to be evaluated completely with a telehealth visit, we are in a case-by-case fashion considering and balancing risks and harms of bringing people to the medical center in order to have them properly evaluated. If there's some question, then we proceed with the telehealth visit, and then certainly if there's any concern after kind of remote evaluation with a provider, then we can absolutely bring people in when necessary to get them appropriately evaluated if there's some sort of concern. So in general, I'd say we are trying to prioritize telehealth and these kind of remote video visits when safe and feasible. And as a backup and when necessary, we're certainly able to see people in person. For our patients who are currently undergoing chemotherapy, they're coming to the medical center anyway. We're still trying to limit their interaction with, our medical assistant screeners, with us, with our nurse practitioners. We're simply trying to minimize the throughput and the number of interactions people are having with each other. So when safe, sometimes we're doing the pre-chemotherapy visits remote as well, even when people are coming to the infusion center. Sometimes we are seeing those people in person. It's case by case and individual. And if people have questions, absolutely direct them our way, and we will figure out how to best accommodate people.
What would you say to someone who does have to come into the clinic? Because I think I was reading recently that the number of people who are going in for a heart attack is even decreasing as people are more concerned about going to the hospital if they don't have COVID symptoms because of the potential exposure. How can you reassure patients who are coming into the clinic about what we're doing to keep everyone safe?
Mm-hmm. That's a great question and a concern for all of us. I'm in a room alone by myself right now, but we do have a universal mask policy in the hospital. So when we're moving through the common areas, when we're moving through common areas in the hospital, we are all wearing masks in order to limit the exposures that we bring to our patients. Patients are also all wearing masks. I think patients should be assured that the medical center and our division also have just tried absolutely to decrease the number of people coming through the medical center. So it's really quite a bit down from where it is. And the no visitor policy, while can be challenging for an individual who wants a support person, people should also feel assured that the other people here coming through are coming through by themselves and that their family members are not coming with them. So we're just trying our absolute best to minimize the number of people coming through. Everyone is screened at the door, and all providers are pre-screened. We have a series of questions we go through every single day when we come in. We get our little sticker every single day. And so you should be assured that we're trying our best to minimize the high-risk people. Here at Mission Bay, where our practices are, we don't have an emergency room and a huge walk-in urgent care. So those services are at our other campus. So we're fortunate in some ways that those exposures are not here at Mission Bay. We do have specifically set up for the COVID pandemic a respiratory screening clinic where if people meet certain criteria or complaining of certain symptoms, we are able to get them screened rather than first sending them to their appointment, potentially exposing others and then down. So we do have a streamlined process of screening and sometimes testing people when appropriate if needed. So we're trying our best to minimize the harms and also provide the necessary cancer care.
Thank you. And I think that's one of the points we're hoping that we can relay to our patients today, that even though it's always terrifying and scary to get a new diagnosis of cancer, potentially even more so now during COVID, but that these wonderful providers who are joining us today, as well as many others who are working as we speak, are here to ensure that that we're taking the most precautions and the best precautions as possible to ensure everyone's safety. Dr. Swanson, I'd like to come back to you in a little bit during Q&A, but I'd like to move on to Dr. Lee Mei Chen to ask about some of the questions regarding regarding surgery and what it's looking like on that side. Dr. Chen, do patients have access to chemotherapy or radiation at UCSF for their gynecologic cancer?
Um, yeah, first I wanted to echo Dr. Swanson's sentiments. Thank you so much for giving us the opportunity to be able to address our patients. I think that this will be a robust discussion where we can talk about some of the needs. I think it is important that patients know that our services remain open and ongoing so that we're performing surgeries and we're also able to provide chemotherapy and radiation services. At the very beginning of the pandemic, as it spread to UCSF, we had a conversation in the cancer center level about the services that we would be able to continue, and chemotherapy and radiation were both felt to be a priority for managing our patients. We have taken some considerations into chemotherapy scheduling. Dr. Swanson mentioned some of the issues that factor into infusion appointments, but getting labs done is still part of how we need to be able to manage our patients, and then having them come in for their infusions. Sometimes we've made some modifications in terms of scheduling or growth factor supports, but those are meant to be able to help improve the risk of immunocompromise as not being something that would increase risk of infection overall. For radiation, it's very important that patients complete their treatment on a schedule. And so if women have started their radiation for cervical cancer, we want to ensure that they're able to finish it. And for cervical cancer, both the external and the internal radiation are essential for being able to cure a patient. And so those services also remain ongoing. And the internal radiation also requires our operating room services, and those we've also made accommodations for to make sure that patients can complete their treatments as recommended on schedule.
Wonderful. And can you speak to us about the surgery that's being performed? Did you have to delay any surgeries? And what plans do you have in place to see patients or perform surgery for the potential backlog you might have?
Yeah, about 6 weeks ago when the pandemic first hit and we weren't sure how strongly San Francisco was going to be affected, we took some pretty radical cuts in our surgery scheduling to be able to allow for potential ORs to be used as ICUs, which they're doing in New York. What we found is that in San Francisco, we have had lower levels, and at our Mission Bay campus, we've been able to continue to use our operating rooms for their intention and purpose of surgery. We do have a group of operating rooms that have special ventilation and are fitted as potential COVID operating rooms. We haven't used them, but we have adjusted the schedule. And by adjusting the schedule, we initially eliminated elective surgery, and over time came up with a system to prioritize what was non-elective. So, emergency surgery needs to happen. Obstetrical surgery like cesarean deliveries obviously need to happen. Patients who are having symptoms from their cancer, bleeding, things that need to get done, we prioritize to a level that we elevated to the top of our surgery schedule. But because we've been able to continue to have some volume, we've been able to move patients through. Initially, when the pandemic hit, we also had a decrease in referrals. I think people were not seeing patients, sending patients to us. And so it kind of matched up a little bit in terms of, there were fewer patients to schedule. But now that we're kind of getting a better understanding of what things are going to look like, the goal is to be able to have operating rooms that are functioning and enough opportunity for the patients who need to have surgery to have surgery. And then the last piece I would mention is making sure we have enough equipment and supplies. Initially, when the pandemic hit us, we also weren't sure what we were going to have as far as masks and other personal protective equipment. And again, as we've understood how the virus spreads, the risk of spreading, what masks are good for, there's N95 masks, there's higher levels of masks that are used in the operating room for patients that are actually positive. By bringing in testing, we're able to work and function to be able to take care of our patients effectively and efficiently.
You mentioned testing. I know there have been some changes to how we're going to be testing patients who are potentially having surgery. Can you tell us a little bit about that? And when we say
Yeah.
testing, sorry, we mean COVID testing.
So testing for COVID-19 is currently a swab test where they're looking for the virus. We're not talking about an antibody test or looking for patients who have been exposed in the past. The testing for COVID-19 is ongoing because it depends on how accurate the tests are, and it depends on the availability of how many tests we can run in a day, and it also depends on how quickly we can get the test turned around. So if we can have testing available, we'd ideally like to be able to test people accurately. So the people who are positive, we find out are positive, and the people who test negative are truly negative. You know, one of the greatest challenges is that there is an asymptomatic spread when people who don't know that they carry the virus come into the hospital, go out of the hospital. But as of last week, the current practice and policy for the medical center is that everyone who is scheduled for surgery will be recommended and asked to have COVID testing in advance of them coming to the hospital. That includes patients who are having interventional radiology procedures, and it also includes patients who are coming in for scheduled chemotherapy admissions. So everyone coming into the hospital will be recommended to get testing in advance, and if they haven't, they'll be tested when they get here. The hope is that we'll be able to identify individuals who are at higher risk, people who are positive, and make a decision with their surgeon and their anesthesia team about whether it's appropriate to proceed. And again, in a cancer patient, we understand that that will take some more conversation than just canceling the surgery. It really will be, again, a prioritization of risks versus benefits for a shared decision.
And I know you said it will be recommended or that we are going to offer testing, but if we have patients coming from out of town, from a few hours away, do they need to come to San Francisco in advance in order to get this testing, or how would you recommend they proceed?
They're offered the testing, and there's even housing that is available locally, so that if someone wants to come into the city to get tested, they can stay overnight at a hotel in advance of their surgery if that's what they wanted to do. We have those resources. If a patient can get tested in their local community, we also would encourage that if they don't want to come down to San Francisco, because they could be tested locally, and we will take that local test result and use that to help inform our decision making. And finally, if it's impossible for the patient to come ahead of time, then what we'll say is that when they get here, we'll have to assess for symptoms and decide again, if someone has a cough or a fever, obviously we would probably want to test that patient and have the information before surgery. But if a woman's asymptomatic, she's coming for her gynecologic cancer surgery, and she hasn't been tested, we would test her as she's coming to the hospital.
Thank you. And I know, and these policies are rapidly changing. There are nuances to it. So any questions, please know that you can always call the number that you have for the Gynecologic Oncology Clinic, and we can provide you with the latest update.
For women who are having surgery, the Prepare Clinic, the preoperative anesthesia clinic, is running the testing. So you may get called from the pre-op anesthesia team asking you to get tested. It's part of our entire process, and know that that's a call that you might get, and they will help navigate you through the process.
Right. I know Dr. Swanson mentioned the visitor policy for outpatient clinics, but I just want to clarify with you, does that also apply to the infusion center or patients who've had surgery as well?
Mm-hmm. The no visitor policy applies for everyone, outpatient and inpatient. And we recognize that for inpatients, there are some challenges because women rely on their families as their support. Women are the support to their families. And so I do think that if families have access to devices where you can FaceTime or have some type of social media, it is important to charge and bring up things, bring up your devices to the hospital when you come. We try and incorporate them into some of our outpatient visits when we can. And certainly on the inpatient side, I think it's how people stay in touch with their families when they're in the hospital. And the teams have, the inpatient teams, my nurse practitioners and residents have also been trying to reach out to families to make sure that people are aware of what's happening for patients who are in the hospital.
Great. And I
I
think
think it's critical because the people coming in and out of the hospital is one of the recognized risks of how the virus can be communicated. And so, you know, what can people do to help themselves is really minimizing visitors is one of those practices that we can all share.
absolutely. Who are the members, other members of your care team that are still working and may reach out? And I have to add, these members have probably always been present, and you, our patients or participants have likely interacted with them in some way, but can you give us an overview of who those people are?
Of course. You know, we try and social distance across the board, so with our patients, but also with our staff. And many of our patients are familiar with our new patient navigator, our new patient scheduler, our practice coordinators, our nursing team, our nurse practitioners. Everyone's working, and most of them are working remotely. We have a small crew that comes in to make sure that, you know, discs that get sent in, slides that get sent in, reports that are sent in are all channeled appropriately. But most of them are working from home. And you may notice that when you call, that you may get a message or you may get the phone tree, but hopefully someone is getting back to you. The nurses, the practice assistants are all making calls. They all have connections and access with one another through our systems. And it's all vetted through the medical center to be patient confidential and secure. So hopefully you don't notice a lot of difference. Where you will notice a difference is check in, check out. For if the people are coming for visits, you'll see fewer people here. But the office staff should be reaching out to you after your appointment and making your scheduled tests and your next visit in a short period of time after you come in.
Great. And should patients be taking extra precautions as shelter in place is potentially lifted? I think we're all kind of worried about,
Yeah.
once this is lifted, what is life as we know it going to look like?
Yeah. I think life as we know it, I mean, this is a great question, is none of us know for sure. I think we all try and get as much information as possible from our leaders and from the sources of truth and knowledge that we have. We know that the virus is not gone. It's not going to go away. We anticipate that there will be outbreaks. And we recognize that the way to control it is through distancing and, you know, hand washing and continuing the practices that we've had to keep the virus at a low level as it has been here in San Francisco. You know, so we're going to continue with practices of video visits for some of our patients, but we are going to ask some of the patients to come in for us to really assess how things are responding to treatment. Sometimes includes a physical examination. Checking a wound obviously will require an actual exploration. But at the same time, you know, if we say we think that this visit should be done through a virtual visit, know that we're trying to keep your safety in mind. When we say that we are not allowing extra visitors, that's also for safety's sake. And like I said, something that everyone can do. We're trying to, you know, make sure that our patients learn how to use Zoom well so that, you know, the 4 of us, 6 of us, however many of us are on this call right now, if patients want to share their appointment ID with a family member who would normally be coming with them, that would be an opportunity for them to bring a family member virtually to the encounter. And even if they can't come into the appointment, we can potentially bring them in for a social media visit when they come into the office. I think we're going to be continuing this for a while. I think testing is going to expand, and at some point we may have what we call point of care testing, which means testing when you get here or testing when you arrive. They may decide to do that at some point for the infusion center. They may decide to do that for the clinics. That's still speculative, you know, things that we don't know and are evolving, but there's been a lot of discussion about where that testing will occur and how it will help us keep everybody safe.
Thank you. And one of the questions that has been on our mind too, as we start to learn more about COVID is, do we have any data about COVID-19 and women's cancers? I mean, that's such a vague question because it's, we know, does COVID-19 affect increase your risk of cancer, or are there worse outcomes for people who have cancer and then get COVID-19? Can you speak to that,
There's
please?
some limited data that have been published from China. There's some information from the UK and Italy of what has been experienced there. The published literature has low numbers, and for women's cancer, I think it's really hard to say with the information that we have. The question is, how does COVID affect cancer? I think there's a question of how does cancer affect a COVID infection? And then what is that going to mean for women who are in survivorship? And does that affect their recurrence risk? And these are all things that the Cancer Center and the University of California Cancer Consortium actually wants to take on as studies. So there are some databases that we're trying to develop and be participating in. The information that we know so far from China would be that for the individuals who have cancer who developed a COVID-19 infection, there weren't any women's cancer patients that we know of. We don't think that the COVID made the cancer specifically worse, nor do we think that the cancer caused their COVID infection to be specifically worse, although many of the individuals who were affected had lung cancer, so that potentially lung cancer and a respiratory illness in combination would result in a worse outcome. We do know that older individuals have higher risk, and we know that men have more risk than women for adverse COVID outcomes. So in a women's cancer, obviously that's a protective benefit, but age, immunocompromise, and exposure, I think are still the big things that I would say are what we think are increasing risk, but we really don't know. And as the pandemic prolongs, how we're changing our practice patterns may have some effect. And that's why it's really important that for symptoms, for surveillance, for labs, for scans that need to get done, we hope that we can get them done safely so we can continue to take care of patients on schedule.
Wonderful. And that's a great segue to introduce Rebecca Gaffar, who's one of our clinical research coordinators. Rebecca, you help people who are enrolled in studies, and you have a higher level view of what's going on with studies. For patients who are enrolled in a research study, where do they stand right now?
Well, at UCSF and the Cancer Center, we're lucky enough to even keep the clinical trial program open at this time. And patients that have already been enrolled in a clinical trial are still able to get their treatments on time. As Dr. Swanson had said earlier, chemotherapy and investigational therapies are still considered essential. So we're all working, all the clinical research coordinators in the Cancer Center are working remotely with the patients and with their doctors to try to navigate how to see patients either in person, via Zoom or over the phone, and come in for treatment.
And so for patients who are enrolled in a clinical trial, were there any interruptions in the trial, or will they continue in the clinical trial?
So far, no treatment interruptions have occurred, at least with our patients in gynecologic oncology. Some groups have experienced delays, but for us so far, nothing really has changed in terms of the patient schedules with either treatment or CT scans.
Great. Is there anything we've been getting multiple emails every day about how research has needed to be delayed or cut off at this time. So it's really reassuring that for our patients who rely on these clinical trials, that they're ongoing, and there have been no delays. Is there anything else patients should know about research studies in terms of population specifically?
Right now, some of the studies have halted clinical trial enrollment. That's usually due to um, lack of people at the medical center, which means like research coordinators being able to get archival tumor tissue to the sponsor to test in order to randomize them onto a trial. But other than that, patients who are already on trial or patients who are already on trial shouldn't really be experiencing too many delays as of right now. But that could also change in the future. Yeah.
If patients are interested in joining a trial or learning about trials, are you still reaching out to them proactively, or how is that working?
Yes, so we're still receiving, we do have a phone number on the clinicaltrials.gov website and the Cancer Center's website, and that goes to one phone tree, which will then triage to the correct group. So we continue to actively screen patients over the phone to see if they could be eligible for one of our open studies. And we're reaching out to patients and their treating physicians just to let them know what's open and if they're eligible and how to schedule.
Okay. I'm just going to summarize it briefly because I think there's a little bit of a delay with the sound. But it sounds like patients who are interested, you are still reaching out to them. There's a phone number on the clinicaltrials.gov website that when patients call gets triaged to you. So any of our patients who might be joining us in the future or who are currently patients of ours can always inquire from either their gynecologic oncologist or from someone like yourself to see if there's any trials that they might be eligible for.
Correct. Yes.
Wonderful. Thank you all. I think I've had a lot of my questions answered during this panel, and I wanted to see if our audience had any questions. There was one question, and I'll open this to Dr. Swanson or Dr. Chen. I think Dr. Chen, you touched on it, but are people with gynecologic cancers at increased risk of contracting the virus? And is it safe for people with gynecologic cancers to be traveling right now via airplane if necessary? Dr. Swanson, can you give us your thoughts?
Sure. Yeah, I think Dr. Chen did touch on this earlier with the data that are available to us at this point about cancer's effects on, or maybe susceptibility towards the COVID infections. And it doesn't seem like, and limited data available for women's cancer, it doesn't seem like just cancer in and of itself is going to predispose one to a COVID-19 infection. As Dr. Chen mentioned earlier, we do know that a risk factor for COVID infections is immune compromise. Some of the treatments that we recommend for the various types of cancers we treat do cause some degree of immune compromise, and so that's something we're very mindful about, and we are talking to our patients about in a one-on-one individual way when that treatment, which is necessary for the cancer, might have that side effect. And so those issues are being discussed on a treatment by treatment basis. But I think overall, just the fact of having cancer wouldn't necessarily increase one's risk for COVID. The question about flying on planes right now, you know, to the best of our knowledge and the public health recommendations we have is just to minimize any sort of airplane travel as much as possible in the spirit of physical distancing, social distancing, and really trying to minimize interactions as much as we can, and we would support that public health recommendation just to epidemiologically try to keep the cases, you know, as minimal as we absolutely can. Of course, emergencies come up, and if one needed to travel, somebody could feel free to reach out to one's treating doctor to talk about specific recommendations to try to minimize risk. But overall, we would agree with the public health recommendations for everyone to try to minimize those things if possible.
Thank you. Dr. Chen, you mentioned patients will be tested if they have uh, a surgery scheduled or if they're going to come in for an interventional radiology appointment, or if they're going to be admitted to the hospital for chemotherapy infusion. How often should people expect to be tested? Or if they're tested when they're coming in for treatment, when do their results, quote unquote, expire?
Yeah, I think this will change as we have different sensitivity and specificity of our testing. Currently, for example, if an individual is coming in for inpatient chemotherapy and a frequent interval of inpatient chemotherapy would be every 3 weeks, they would be expected to have testing in advance of each admission every 3 weeks. If someone is in the hospital and they were tested when they came in, but then they have to go to surgery for a procedure, if it's been more than 7 days, they would be recommended to have a retest. But not because they're in the hospital, but if they're having a procedure that would require an intubation, something that would be generating aerosol and potential spread of virus, I think that at that point, we would currently be testing again. This is changing, but this is our current practice. And for the outpatient side, there is not a standard practice to test patients coming in for chemotherapy. That's just on the inpatient side for now.
Great. Do you, Dr. Swanson, Dr. Chen, Rebecca, any other last thoughts to leave with our patients today? I think we've covered many topics right now, but
I would just add, and this really goes for all of us, but you know, the added stress that this pandemic has had on people in a practical way in terms of exposure, but also in a psychological and also in a spiritual way. You know, this is an unprecedented time that we are all moving through, and if the weight of this pandemic on top of the weight of a new or not even necessarily new, but just really any cancer diagnosis, the interplay there can really be exponential. And if people are feeling stress, if they're feeling alone, if they're feeling just greater stress than they feel they can manage, we would just encourage them to reach out to us. We have social work support here. We have support groups. We have resources, and please do not hesitate to reach out. It's something that we're thinking about all of our patients and really all of us in this time. It's a challenging time. It's unprecedented, and please don't, you know, do not hesitate to reach out to us, and we can try as best we can to get people connected to support.
And Dr. Swanson, I should mention too that UCSF Psychiatry has a great website. So all you have to do is Google UCSF Psychiatry Coronavirus Family, and they have a wonderful website that goes through resources for people really from all walks of life that are free for anyone to make use of.
Absolutely, thank you.
Dr. Harmofar, there's a question from the Q&A that I wanted to just tackle, if I could.
Yes.
The question is, are patients on PARP inhibitors at higher risk for virus other than previously stated factors? PARP inhibitors are a class of drug that are used to treat ovarian cancer, and it's an oral agent that patients can take. And in terms of how we think about it, we do think about it as an anti-cancer therapy, an anti-neoplastic therapy, an oncolytic therapy. It does have some effect on on your immune system, but just like any other chemotherapy, we monitor those with checking labs. And so in terms of the recommendations to check a CBC, to follow tumor markers, I think as long as we stay along those guidelines, we should be able to stay safe and give recommendations if we need to make adjustments. I think that my messaging would be that we are going to be practicing in the COVID landscape for a long time to come, and that we are going to need to look at what is essentially a new normal. And in this new normal state, we are still here to take care of women with gynecologic cancers. And we have a full complement of services. We have a strong team. We have a very dedicated research staff. And if there's questions that come up, please ask us. We're doing our best, and we will continue to take care of you. In terms of being concerned about distancing and outreach, I think that, you know, we're trying to give examples between MyChart, social media, Zoom, really to be able to keep in touch with you all. So let us know what's going on so we can help you. And if it becomes to the point where we say, we need to see you, we need to do a test, it's because we think that that's in your best interest, and we hope to continue to work together for that.
Thank you, Dr. Chen, Dr. Swanson, Rebecca. I always end with this, but it really is a privilege to work alongside such thoughtful and brilliant minds who are committed to women's health. We started this series because we were aware as providers what we were doing to help our patients, but we wanted to make sure our patients understood what is available to them, what they can expect from their visits or their surgeries when they come. And I appreciate you highlighting everything that the Gynecologic Oncology department is doing to make sure that it's still positioned to be able to offer the vital care that it does. I also want to thank Brooke Peterson, the Project and Access, one of the Project and Access managers at UCSF Women's Health, Bertina Lee and Bernardine Tortorelli at the Women's Health Resource Center for helping us put this together. We will have a recording of this webinar available in the next few days. Feel free to our participants to share it with your family and friends, or any other friends you might have that get their care at UCSF. We'll be sending a post-webinar evaluation as well. So if you have any thoughts about future webinars that you'd want us to plan, or how we can improve this series, we'd love to hear from you. I hope you all enjoy the rest of your day. Thank you for taking time out of your busy days to join us today, and look forward to a time when we can understand what this new normal is going to look like and feel comfortable in how we're operating on a daily basis. Thank you all. Have a good day.
Thank you.
Thank you.